now.
Okay.
And this webinar is part of the Gold Star Medical Billing School's training series called Understanding Insurance and the Health Insurance Industry. You know, if you're going to have a career as a medical biller, it's important that you understand your field of expertise. And in this class, what you're going to learn is what is health insurance. I'm just going to talk about a very brief history of health insurance. Actually, in my actual billing school, and I do a 2-week boot camp billing school about twice a year here in San Angelo, Texas, which is where I'm from. And we go through a lot more of the history of health insurance, but we'll just do a very brief overview of the history of health insurance in this particular webinar. We'll talk about the different types of health insurance that are out there. We'll talk about supplemental and complementary payers, and we're going to talk about how health insurance plans are administered as well as benefit structures. Benefit structures are very, very important to understand because it will help you then understand how to handle patient collections when you understand how patient benefits are structured. So this is going to be the brief overview of what we're going to talk about today. Now, health insurance, as far as the definition of it, is defined as protection against loss by or through illness or bodily injury. Health insurance usually provides coverage for medicine, visits to the doctor, or emergency room, hospital stays, and other medical expenses. And actually, you know, it's always interesting, if you have health insurance, you'll usually get a big booklet called your Summary Plan of Benefits. And in that booklet, it outlines everything that your insurance covers. And people don't often read that, but sometimes there's coverage in your own personal insurance plans. And if you do have insurance, I would encourage you to go, as a way to learn more about insurance, is read your own insurance policy summary plan of benefits. Because you'll find out that there may be things covered, like, for example, if you have to go out of town to have a specialist evaluate you for a medical condition, like the Mayo Clinic, for example. Did you know that many insurance plans will cover your hotel stay and some of your travel expenses to and from that visit? People don't realize that, and so that will go out of, you know, that will go out of your pocket, and you never get the insurance company to reimburse you for that. And that could be a reimbursable part of your own personal health insurance. Other things that are commonly reimbursable are like for an accident. So if you had a slip and fall, some policies will allow for like the first $500 of health you know, claims to be paid at 100% with no deductible. And so these health insurance policies have a lot of interesting features within the policies themselves. Nowadays, many policies, especially the ones under Obamacare, will have clauses in the policy for specific wellness type examinations and evaluations for women. So, for example, my health insurance, which is through Humana, I'm allowed a mammogram every 3 years, free of charge. Okay, a diagnostic, not a diagnostic, but a mammogram screening, free of charge. And an annual wellness visit, free of charge, you know, billed out at 100%. And these are things that many people don't, you know, they use their health insurance if they go to the doctor or if they go to the hospital or the ER, but they don't realize that their health insurance covers a lot more than just that. So those other medical expenses can be a big benefit for you who have insurance. Okay. Health insurance can be directly purchased by an individual, or it can be provided through an employer. If it's provided through an employer, it's called group health insurance. Okay, and there are also federal and state programs such as Medicare, Medicaid, which provide health insurance to people who are elderly, disabled, or of low-income individuals. There are a number of companies, sometimes called insurance carriers, that write private employer-paid health insurance plans. Some of these most common carriers that we hear all the time are Blue Cross Blue Shield, United Healthcare, Aetna, Cigna, Humana. Your particular state may have some type of a state health plan that's very common within your state. For instance, in Texas, where I'm from, Scott and White, which is a big medical conglomerate in the central part of Texas, has their own insurance plan. So a lot of people in Texas carry Scott and White insurance. And so, but that's pretty much indigenous to Texas. But the ones that I have here on the screen are national companies. You'll find these insurance carriers all across the United States, okay? Insurance can also be available through an employer for work-related injuries, which is called work comp, or through an automobile policy or accidental insurance policy for medical expenses that are incurred as a result of an auto accident or accidental injury. So there's a lot of ways medical expenses can be paid, and we'll explore all of them here today. Obamacare is officially known as the Patient Protection and Affordable Care Act. It was signed into law March 23rd of 2010. It was upheld by a Supreme Court ruling on June 28th, 2012. And basically what it did was required all individuals to purchase health insurance by 2014 or incur a tax penalty of anywhere from 1 to 2.5%, and I think it's up to $1,080 tax penalty. And there is, I believe there is a cap to that. But if individuals are already covered by health insurance, there's really no change except that maybe your employer or your patient's employers will look for cheaper plans using the Employer Health Insurance Exchange. And individuals will be able to go to the state insurance exchange to shop for low-cost insurance. One of the things that we've seen as a result of Obamacare is that more individuals will qualify for Medicare or Medicaid or receive tax breaks or incentives if they can't afford to purchase insurance. You know, I know a lot of providers will shy away from Medicare and Medicaid, and I understand why. You know, the reimbursements are generally a bit lower than commercial plans, and they are a lot harder to deal with. However, one of the things that I am seeing is that every year there's a significant increase of population that are added to the Medicare and Medicaid rolls. And as a result, there is probably going to come a time when it will be detrimental to your business if you do not take Medicare and Medicaid. Now, for behavioral health, Vicki, I'm not sure if you're aware of all of this or not, but for behavioral health, only certain practitioners can accept Medicare and Medicaid. So, for instance, an LPC cannot bill Medicare, but a PsyD can. So if you're a doctor of psychology or if you're a clinical social worker, you can bill Medicare. Of course, if you're an MD psychiatrist, you can bill Medicare. Medicaid, each state has its own rules as to which types of providers, behavioral health providers, can bill for Medicaid. In some cases, LPCs can bill Medicaid, and in some states they cannot. So what state are you guys in? You're in Georgia?
Georgia.
Georgia. Do you know if your LPCs can bill for Medicaid?
They cannot.
They cannot. Okay. So some states can and some cannot. And really a lot of it depends, frankly, on the shortage areas. So if, for example, Wyoming, Nebraska, North Dakota, South Dakota, Idaho, LPCs could bill Medicaid because there are so many people on Medicaid and there aren't enough behavioral health specialists. You see what I'm saying?
Yes.
So in Georgia, obviously, you have a good ratio of behavioral health specialists who can bill Medicaid, so they don't have to bring the LPCs into the Medicaid rolls.
Right.
Okay. I just wanted to show you this. We were talking about kind of the history of insurance. This is an actual insurance policy from the mid-19th century, which is like the mid-1800s, and
Wow.
this is it. This is your insurance policy. Can you imagine now? It says, okay,
Yeah.
covering the risk of accidents and infectious diseases, granting you an annuity, okay, sums insured up to £4,000. This is from England, okay. Disablement allows up to $12 a week and an annuity of up to, in other words, a yearly annuity of up to £60. And that's it. That's what you got, So, if you showed a doctor this policy, this would be acceptable. It doesn't even have to have your name on it. So,
Wow.
yeah. That's how much insurance has changed from in the last 150 years. But I know people get a chuckle out of that when I show it to them. Okay, so let's talk about the different types of health insurance that are out there. You have, and ladies, at any time, if you want to pop in and ask a question, this is kind of your time. So by all means, as long as we don't get off on a lot of rabbit trails, we'll just answer any questions that you might have with respect to any of this topic, okay? So we're talking about the different types of health insurance. We have what are called group or individual policies. And as I said before, the group policies are called group policies because the employer pays a portion or all of the premiums. The larger the group and the lower the premiums. And it operates under the concept of a risk pool, okay? And it's kind of important for you to know what the concept of the risk pool is. I'm going to use this as an example, going back to the history of insurance. One of the earliest concepts of insurance was actually came about around 3000 BC with Chinese merchants, shipping merchants. And basically what had happened is, as the story goes, and of course this was a long, long time ago, but 5,000 years ago, but the story goes, and as it's been handed down, is that there was a Chinese shipping merchant who had a large cargo of gold, and that he was taking down down this large river and out into the ocean. He got into the ocean with his cargo, and there was a storm, and the ship sank. Okay, and he lost his entire cargo. Well, from there, the shipping merchant realized that if he took his cargo and spent a little bit more money and built 10 ships and took his cargo and put 1/10 of his cargo on each ship, he would have a better chance of the majority of that cargo reaching its destination. And so that's the earliest, in other words, he was insuring his cargo against loss by taking the risk and dividing it out amongst a number of different ships, okay? And not only did he, this shipping merchant, make his cargo go out into the different ships, but he would make them go out at different times. So they wouldn't all go out at once. One went out one week, one went out another week, so that if there was a storm and one sank in the ocean or it was destroyed for whatever reason, he still had 9/10 of his cargo. And that is called the risk pool. The way that works in insurance is if you have a company like IBM that has, let's say, and I don't know how many employees they have, but let's say nationwide they have 60,000 employees in IBM, and you have an insurance carrier that covers that IBM group, then you have basically 60,000 people paying premiums into, or departments within IBM paying premiums into that insurance carrier. And let's say 1/10 of those people actually use the insurance. Well, that's 6,000 people. So if 6,000 out of 60,000 are using the insurance, the money being paid in by the other 54,000 are paying the medical expenses of the 6 that actually need it. That's why you will find that the larger the company, the better the benefits, because the risk pool is diluted out amongst so many people. On the other hand, you have the individual policies where the individuals pay 100% of the premium. Well, who is the risk pool? The risk pool is that one person. So the insurance company takes a tremendous risk on the individual policy by covering that person, and if that person does have the medical expenses, then the insurance carrier is having to pull money from other premiums that have been paid into that policy to pay that other individual's health insurance or health claims. Okay. So there are some non-employer risk pools available, and sometimes that will help an individual. That's why individual premiums are so much higher than group policies. But there are some non-employer risk pools, like for instance, there's a company out called the NASE, which is the National Association of Self-Employeds. They actually, if you belong to that association, that becomes your risk pool. So they have optional health insurance coverage that you can purchase through the NASE that offers you a little bit lower premiums, because if now you have, let's say, 5,000 members of the NASE nationwide that are contributing to that risk pool. So that's how the risk pool concept works. You have commercial carriers. Now they usually are the ones who administer these types of policies. And the commercial carriers, again, are represented by companies such as Blue Cross, Aetna, Humana, United Healthcare, and so on. So you have the different types of insurance. Now within that insurance, they have different types of plans, okay? So what we're going to do is we're going to look at insurance as if we're peeling away the layers of an onion, okay? And the types of plans within different types of health insurance are usually referred to as managed care plans, okay? Managed care plans are plans in which an insurance company will direct cost and utilization, okay, by having stipulations within their policies for what they will pay for, what they won't pay for, and other types of criteria. Now, you have two types of managed care plans. You have what are called in-network plans, okay, and you have out-of-network plans. And this is very important to know. It's very important that you know the difference, and it's very important to know what plans, and within the plans, with what contracts your provider belongs to, okay? Because within those contracts, you're going to have certain treatment parameters for your patients, and you're going to need to know what those treatment parameters are for each plan so that you can correctly collect what the patient would be responsible for, write off what the contract stipulates, and know what to expect as far as payment from the insurance company. So it's really important to know these differences. Now, in-network plans are usually broken down into two types, which are the large umbrella name for these two types of in-network plans would be PPOs and HMOs. PPO standing for Preferred Provider Organization, HMOs standing for Health Maintenance Organization. Now, under a PPO plan, and you will generally know what type of a plan your patient has if you look at their card. And if you can't tell by their card, you would need to call, of course, and verify benefits. But most cards will say something like, you know, at the top of the insurance card, it'll say Blue Cross Blue Shield of Georgia or Anthem Blue Cross of Georgia, something like that. And then next to it, usually on the right side or just directly below it, it will tell you the type of plan that it is. So it might say something like Blue Access PPO or Blue Provider Care Plan or Blue HMO, okay? And that will help you determine whether you're dealing with a PPO or an HMO. In behavioral health, this is especially important because most, if not all, HMOs will absolutely require a referral from a primary care doctor, okay? Many of the PPOs require not referral but pre-authorization for behavioral health. So it's important to know how the behavioral health plans work in your area and to know where to go and what to do to manage these different types of authorizations that may be necessary. In a PPO plan, a patient generally has a choice as to whether they see a doctor in their network or out of their network. And you know what? There are some patients who say, you know what, I don't care how much it costs me because it will cost them more to see an out-of-network doctor than if they see an in-network doctor. But, you know, some patients say, I don't care how much it costs. I know that this doctor or this counselor is wonderful and this is where I want to go, and I'm willing to pay the additional money to see an out-of-network doctor. If they have a PPO, they usually have that choice. If they have an HMO, though, they usually do not have that choice. And so it is very important to make sure that if you do come across a plan from a patient who has an HMO, that you identify that very quickly and make sure that your providers are contracted with that HMO. Now, let me just tell you, just because, let's say you have all of your providers are contracted with Blue Cross of Georgia or Anthem of Georgia, which is a Blue Cross plan. If just because they're contracted with Blue Cross, that's just the umbrella, okay? Now, underneath that credentialing is what is called contracting. And so just because they're, you know, in Blue Cross doesn't mean they're in network under all the contracts that Blue Cross has or all of the different types of plans that Blue Cross offers in the state of Georgia, okay? So you have to be very careful that you don't just assume that if a patient brings you an insurance card and it says Blue Cross, you're like, oh, okay, well, we're in network, but you don't then really delve into it any farther and then come to find out that this is a Blue Cross HMO and you're not in network or your provider is not in network with that plan. So contracting and credentialing can be a little tricky, especially in behavioral health. And so you do need to make sure that you have a really good understanding of the different types of plans and the different types of networks that your providers belong to. And you are dealing with multiple providers, so you know contracting and credentialing is a little bit more complicated because of that, because you may have some providers that are contracted under certain plans and some that are not. And so anyway, that's just something to kind of watch out for. I always look at little red flags, especially in the industry that I'm teaching and under behavioral health. This is a big red flag, is knowing what the contracts are and knowing whether your patients actually have a choice as to whether they can see your doctor or not, or see your provider or not. Out-of-network plans, these are non-contracted. HCP stands for healthcare practitioners, so non-contracted healthcare practitioners. Some practitioners choose to stay out-of-network on all of the plans. And if that's the case, then the fee is billed out, and the bill fee is just then paid or denied. Most out-of-network plans are not assigned. And what I mean by that, and this is, again, this is very important to know, if you have any, let me ask you this question. Do you have any plans that you guys are out-of-network with that you accept insurance on?
When it comes to the out-of-network, we generally, unless they have a secondary, unless they have Medicaid as a secondary, which we are contracted with, and we know that they will generally pay. That's the only case when we file out-of-network. It's just if it's a case where the primary is out-of-network, but the secondary is a Medicaid.
Okay. So the thing to watch out for in cases like that is occasionally on the out-of-network plans, let's say, for example, the patient, you have this out-of-network plan that you bill for, so that you can get the denial to send over to or you can get the payment information to send over to Medicaid. So let's say the plan paid something out of network. It will generally pay the patient, okay? And as such, then you bill it to Medicaid. Well, come to find out that their Medicaid had lapsed, or they were no longer eligible for Medicaid on that date of service. So now you've billed the primary, then the patient has gotten paid and you have not gotten paid. So the bottom line with out-of-network plans is if they are out-of-network, you should get your payment up front from the patient, okay? Or at least have a way to guarantee that payment in the event the secondary does not pay, okay? So that's something that we'll actually talk about a lot more in our patient collections portion of one of the webinars that I'm going to be doing for you, is on all about, how to handle patient collections. But just knowing the different types of health insurance, if you come across a patient and you're not in network with that patient, you should have a lot of little bells and alarms going off in your head on, okay, how are we going to handle collections on this? Because it's going to be different. Even if you do the billing, it doesn't mean the insurance company will pay you. Out-of-network plans, there are a lot of doctors out there who will, as a courtesy to their patients, go ahead and bill for the patient, but they still will not get paid. And not only do you not get paid sometimes, but you don't even get an EOB letting you know that the patient was paid. So, I've run into situations numerous times where I'm consulting with a doctor's office and they're out of network on certain plans, but they bill the insurance and don't collect from the patient, or they just collect a small copay, and I'm like, well, how do you know if the insurance has already paid the patient? They're like, well, we don't know. I said, yeah, you don't know. So you need to make sure you collect all that up front and then go ahead and bill it, but let the patient deal with their, whatever comes in. If they get paid, they get paid. That's fine. You've already gotten your money. So out-of-network plans can be a little tricky. The healthcare practitioner on the in-network plans, you have to bill, or not bill for, but at least collect only the amounts that are allowed by that network contract. Okay, so you're going to be given, when you contract with a specific insurance company, that insurance company is going to provide you with a fee schedule that you will have to abide by. So if you bill, let's say, $150 for a diagnostic evaluation, 90791, that insurance carrier may only allow $75 for that per their fee schedule. The difference in the managed care in network plans you cannot collect for. In the out-of-network plans you can collect for. Okay, because some insurance carriers, you may bill out of network, and they will actually give you what's called a recommended UCR, which is usual. It stands for usual, customary, and reasonable reduction. And the patient will look at that and think, oh, they're supposed to write that off. But if you look at the bottom of the EOB makes the entire amount the patient responsibility. So on the out-of-network plans, you are not bound to a fee schedule, even if there is one suggested on the EOB. So that's something else to be careful about when you're looking at those EOBs, as far as whether you should be charging the patient or not. The bottom of the EOB will tell you, you know, a lot more information about what that patient responsibility actually is, okay? You also have what are called self-insured plans, and these are usually large companies that fund their own insurance plans and then contract with an insurance company to manage it, okay? Or they may use a third-party administrator or a TPA. Other types of health insurance, moving on, are your federal and state entitlement policies, such as Medicare, which is entirely federal, for individuals who are retired or who are on SSI disability. The end-stage renal disease program, which I'm sure you would not really have much to do with. Medicaid SHIP, which is state children's health insurance plan. These are usually funded 50% by the state and 50% by the federal government, so it is still a federal program, and it does fall under the auspices of the Department of Health and Human Services, okay, as well as the state regulatory bodies that regulate the Medicaid program within your state. These are usually for individuals who are on reduced or no income, who are on a financial hardship. It's usually based on a monthly household income. Most states require individuals to requalify monthly for benefits so that if their financial situation changes, they no longer are eligible for Medicaid. And that's, for Medicaid, that's probably one of the trickiest parts of managing your Medicaid patients, is remembering to requalify them every single month. So, you know, you may be on a treatment plan with a patient. Let's say you see a patient at the end of this month, the last week of September, and they're eligible for Medicaid. Well, when they come back for their visit the following week in October, you must requalify to make sure that they still are eligible for Medicaid, because there's a chance that they're not. And I've seen a lot of cases where claims are paid one month and then denied the next month because the patient's gotten a job and now they no longer fall under Medicaid, okay?
Right.
So that's a real tricky part with Medicaid, just to make sure that you're aware of that and that you stay on top of that and have some kind of a plan in place to check on all of your Medicaid patients. A fiscal intermediary is a commercial insurance carrier that is contracted by a federal or state agency to accept, process, and pay claims. And so it's important for you to know what fiscal intermediaries you're working with. You guys, it's my understanding that you don't bill any Medicare at this point. But for instance, if you were to bill Medicare, you would not bill claims to Medicare. All right, you would bill claims in your state to a fiscal intermediary named Palmetto GBA. Palmetto is the insurance company that administers the Medicare. They actually were awarded a contract by the federal government to administer Medicare claims in your state, okay? And so that's what a fiscal intermediary is. In Medicaid, sometimes there's multiple fiscal intermediaries. I don't know how it is in Georgia, but for instance, in Texas, a Medicaid patient could be billed under one of 5 different plans. And so it makes it very complicated to know where to bill Medicaid claims, because you don't bill them to Medicaid. You may bill them to, you know, AmeriChoice or Simpatico, or, you know, and there's all of these different plans, and those can change from month to month. So every month we have to be, in Texas, we have to be reconfirming a patient's Medicare benefits, not only whether they have benefits, but where the claim should be billed to, okay? And under that, knowing your doctor's contracts, because it can even get as crazy as the doctor can be contracted with, or the healthcare practitioner can be contracted with Medicaid, with the state program, but then there are some Medicaid managed care programs that they're not contracted with, and it's nuts. You know, to me, that's some of the most complicated components of insurance, is you get these claims that are denied, and you're thinking, well, they paid last month, and what, why, and they're
Right.
saying, well, the patient has other insurance, and you're thinking, no, they have Medicaid, but what they mean by other insurance is it goes to a different plan this month, So,
Right.
yeah, so those are the types of things that you have to deal with. Vicki, I hope I'm not scaring you off.
No, actually, we actually check or verify eligibility on all the Medicaids every day prior to them coming in. We don't actually do it even at the beginning of the month, but prior to every visit.
Awesome.
So that's actually something she's been working on already.
Yep. Yeah, and you will find the longer you do it, you're going to find that these things are ever changing, so it's really important to stay on top of it. Okay, so a third-party administrator is not an insurance company, okay? I want you to understand that. Commercial insurance carriers will contract with TPAs to accept, process, and pay claims on behalf of that carrier. And this is a fairly common relationship. In behavioral health, it's really common because a lot of times when you verify benefits, let's say you call United Healthcare or you call Cigna, for instance, and you call the general telephone number, and it will ask you, for medical, press 1, for dental, press 2, for behavioral health, press 3, and then you press 3 and it will say, for behavioral health benefits, please call Cigna One Behavioral Health at such and such and such a number. Okay, and then they hang up on you, and then you have to go call, Cigna Behavioral Health. Sometimes they don't even call it by that insurance company. So, for example, United Healthcare contracts with Optum, and Optum is a third-party administrator. They are not an insurance company. Value Options is not an insurance company. EAP, Employee Assistance Plans, are not insurance companies. But it's very hard to make patients understand that, And so, so the relationship between insurance carriers and TPAs is fairly common. It's usually a behind-the-scenes type of thing that goes on that we as healthcare practitioners know about, but the patients don't often know about. So, they'll try to call their insurance company to find out information, especially on behavioral health, and not really get good answers. And so they come very undereducated as to what their benefits are when they come to you. And of course, they can't handle stress as it is, so try to have them call an insurance company and stay on the phone for 10 or 15 minutes, or longer to find out what their benefits are. That could just, elevate their stress levels to no end. So we, of course, in behavioral health, we try to help them out as much as we can to keep this as simple as possible. But other types of personal injury could be auto or other accident, non-work related. I don't see this much in general counseling. However, I have seen, I do billing for a psychiatrist in California, and he does actually a lot of personal injury and work comp claims. And basically what happens is he does the counseling for patients who have been involved in a traumatic auto accident or traumatic work-related injury, or patients who have lost income or lost their jobs or their entire careers because of a career-ending injury. And so the patients go to him for counseling, and he specializes in that. So we do a lot of personal injury and work comp billing for his particular specialty. But that's sort of a niche in behavioral health, and if you have that niche, then I'll be happy to talk to you about that. But if you don't, then it's not something that we have to spend too much time on.
Right. Yeah, it's not something we really see here.
Yeah, yeah. FECA is work comp for federal employees, okay? And the federal Black Lung Program is a work comp disability benefit for individuals diagnosed with black lung disease, such as coal miners. So these are the types of health insurance that you may come across throughout your career in medical billing. Now, how claims are administered. So let's just talk about the flow of how this all works. A beneficiary has an illness of some type or an injury, and then they decide that they're going to visit the physician, or in your case, a behavioral health specialist, a healthcare practitioner. The practitioner will perform an evaluation on the patient, formulate a diagnosis, and render treatment. Okay. Then from there, the information on that health encounter is sent directly to the patient's insurance carrier, or sometimes a third-party administrator or a TPA. So the flow of this is, and I'm going to use my little highlighter, I think it's really cool. So first, the carrier is going to review the claim against patient benefits, okay? When it is received by the insurance company, they're going to look, first of all, to see if the patient even has benefits for behavioral health, okay? If they don't, then it's automatically going to be denied back to the provider, okay? And then you're going to inform the patient of that carrier's decision, okay? But if the claim is paid, then the carrier will either recommend payment or denial, and if there is a TPA involved, they will forward that claim to the third-party administrator, okay? If not, then either the carrier or the TPA will then pay or deny the claim based on two things: the patient benefits, okay, what is allowed under their coverage, okay, and the managed care agreement with the provider, okay? So they're going to look at the benefits, and yes, this patient does have behavioral health. It does allow for one diagnostic evaluation per calendar year. The patient has not used that, so yes, we can pay that claim for the 90791, okay? And then they're going to look at the fee schedule. They'll look to see whether your provider is in network or out of network, and if the provider is in network, then they're going to go to the fee schedule for that 90791 code, and then they're going to pay that based on what the benefits are. So if the patient, let's say 90791 is covered at $75 based on the fee schedule, and the patient has a $30 copay, okay? And if the patient has a $30 copay, then you're going to get a check of payment sent to the provider if the benefits are assigned, meaning if the doctor is in network, and if not, then it's going to be sent to the patient. But if you're in network, then you're going to get a check for $45 because you're going to bill, let's say, $100 for that diagnostic eval. They cover $75. The patient has a copay of $30. That leaves $45. So you'll get paid $45, and you'll have to write off the difference between what you billed and what the insurance company paid, which is that $25 difference. Okay, does that make sense?
Mm-hmm.
Mm-hmm.
Okay. If you bill to a third-party administrator, then it's the same thing. It's just that the TPA reviews the claim against the patient benefits. Usually a TPA is involved when pre-authorizations are necessary, so the TPA is also going to check to see if there's a pre-auth. And if there is, and everything looks good, then they're going to recommend the payment or denial. They will price the claim and then send back to the carrier. The carrier usually cuts the check or denies the claim, and then that payment denial is sent to the provider if the benefits are assigned, patient if not assigned, and then just as if it's a direct bill to the carrier, the patient and the provider are informed of the carrier's decision. Okay? That makes sense to everybody?
Yeah.
Mm-hmm.
Okay, perfect. Let's move on. Are we doing okay on time?
Yeah, I think so.
Okay. Okay, my screen just froze up on me. I'm not sure why. Hold on. Oh, there we are. Okay, other factors that can affect claims administration are pre-certifications or pre-auths, case manager coordination of care, and peer reviews. Now, pre-certs, pre-auths are fairly common in behavioral health, so we have to be very careful about that. Case manager coordination of care. If you have a patient that has a significant illness, for example, you know, there are some behavioral health specialists that work with, for example, cancer patients or patients with significant chronic illnesses, and as a result, they suffer from depression. Oftentimes, a case manager will be assigned to that patient, and all claims, if a case manager is assigned, will go to the case manager first to make sure that there's no duplication of services being performed, to make sure that, you know, the patient isn't going to see you and then maybe they're going to, you know, another counselor down the road on another day because they feel like they need more counseling than they're getting, that type of thing. So the case manager makes sure that that's not happening. Sometimes if a case manager is involved, you'll find that it takes a little longer to get paid as the case manager reviews all of the data that's being sent in, okay? And a peer review takes place when the insurance company suspects that their overutilization of services may be taking place, that the patient may be going too many times, or the healthcare practitioner is billing for too much service based on the diagnosis code that's rendered. They'll kick it to a peer review, so another counselor will review those claims and review the healthcare practitioner's notes to see if the claims are medically necessary. The other side of insurance is patient benefits. Most doctors and healthcare practitioners need to understand that nowadays you're only going to receive about 40% of your payment from the insurance company nationally, and this is national averages, okay? Now it might be higher in your area, it might even be lower, but most managed care agreements, if you bill out the services based on your clinic's fee schedule, they're going to require you to take a contractual write-off of anywhere from 20 to 30% or even higher in some cases. And then the remaining portion comes from the patient. So understanding what to collect from the patient is really crucial to keeping healthy cash flow. And I will tell you, you know, because of the nature of what you do in behavioral health, your patients already are a little more fragile than other patients. And so to try to make the collection process as stress-free as possible is going to be very important, because you know, if they don't understand, if they're stressed out about it, it's not conducive to their treatment, okay? So, you know, this is going to be kind of an important part to make sure that the patients are all, you know, you have a really solid but reasonable collection process for your patient collections that you kind of stick to, and your patients know they can count on, okay, that it's going to be a certain way. This is what they're going to owe. This is what they're going to have to pay. This is what will happen if the insurance company doesn't pay. So they have a real clear understanding of that. So some of the things that we need to know as far as on the patient side of things is that, you know, patients pay out a lot of money to have insurance. And if you have insurance, you know that's the case. You know, you may have insurance through your company, but, you know, maybe your family members you still have to pay for. But the bottom line is it all starts with the premium, okay? An insurance premium is paid either by the employer, the patient, you know, sometimes the premium is split with the employer and the employee, okay? Or the employee pays for their family members' premiums, but the employer pays theirs. And you would think that that would be the end of it. They pay the premium and now they have insurance and the insurance company covers everything, but not so. Before the insurance company will even pay a dime, okay, in some cases a patient is going to have a deductible to meet, okay? And in some cases they're going to have a copay. A deductible is a fixed amount that a dollar amount that the patient will have to pay out of their pocket before the insurance company pays a dime, okay? A copay is a fixed amount, just like a deductible, but it's a fixed amount, but it is a payment that the patient needs to pay at every visit. regardless of how much that visit costs. So the difference between a copay and a coinsurance is a copay, the visit might cost $250 or the visit might cost $100. The patient still only pays $30. That's a copay. Okay? Under coinsurance, it's a percentage. So there'll be a deductible in many, many, many cases under this type of a track, which is a deductible coinsurance track or a copay track. Under the deductible coinsurance track, there's a deductible that has to be met, and it can be met under a number of different providers, so it's not just you. So for example, the patient may be coming to see you for behavioral health counseling. They may be going to see their oncologist for cancer treatment. They may be going to see their primary care provider, for just general checkups. And every time they incur expenses, those expenses go against the deductible. It doesn't matter who. So once the deductible is met, then the coinsurance kicks in, and that is usually a percentage, usually less than the patient would pay. So, I mean, the insurance company would pay. So the coinsurance is usually 20% or 30%, and then the insurance company pays the remainder of, again, the allowable charges based on the fee schedule. Okay, are you following me on all of that?
Mm-hmm. Yeah.
Yes? Vicki?
Mm-hmm. Yeah.
Okay. Yes. I'm with you so far.
On the copay, the insurance pays the remainder of the allowable charges. So, for example, okay, we have, $100 charge, and I'm doing this with my right hand and I'm left-handed, okay? We have a $100 charge. The patient has a $1,000 deductible and they haven't met it. How much of that $100 charge is the insurance going to pay?
No.
Zero.
Zero, because it all goes against the deductible. Okay.
Mm-hmm.
Right.
The patient has met the deductible. Okay, and the doctor is out of network, and the patient has a 30% coinsurance. How much is the insurance going to pay?
Zero.
Yeah.
No,
Network.
the patient has met their
Well,
deductible.
if it's out of network.
Well, it doesn't matter because they can see an out-of-network doctor, and they have an out-of-network coinsurance of 30%. Okay?
Okay.
So the deductible is met. They have a 30% out-of-network coinsurance. How much will the insurance company pay?
70%.
$70. So yeah, so they'll pay $70. Well, now we have this patient. They have the deductible, but the deductible is met, so we don't have to worry about the deductible. Okay. They have the coinsurance of 30%, but the allowable charge is $70 of the $100 that you billed. So if the allowable charge is $70, how much will they pay?
Just the 30% of the $70.
That's right. Well, the patient will pay the 30% of the $70, which is
Right.
$1,
Yeah, sorry.
right? And the insurance company would cut a check for $49. And then you would have to write off $30, right?
Right.
Mm-hmm.
Mm-hmm.
Does that make sense?
Mm-hmm.
Okay, awesome. Oops, I have to erase. Again, whenever I use this feature, my computer freezes, so I probably should. There we go. All right. Other factors that might affect a patient's fiscal responsibility or what they owe you would be things like out-of-pocket limits. Do you all understand what out-of-pocket is?
Yes, I mean, I don't understand, I guess, if when you're paying your copay, does that go towards your out-of-pocket?
It depends, and that's where verifying benefits will help. So when you verify benefits, you would ask whether that copay applied to out-of-pocket limits. Sometimes the copay will apply, sometimes the deductible will apply to out-of-pocket limits, and sometimes it won't. It depends on how the policy is written. But basically,
Okay.
what out-of-pocket limit is if we come back up to this deductible and coinsurance, okay, and you have the combination, let's say that the out-of-pocket applies to the deductible and the coinsurance, okay, and let's say the out-of-pocket is $10,000. Okay, so once the patient, and let's say in this example the patient has a $5,000 deductible and then a 30% coinsurance. So once they have paid their $5,000 deductible plus enough coinsurance money to bring it up to $10,000, then, and they've reached that $10,000 threshold, then under the out-of-pocket clause, the insurance would pay 100% instead of 70%. Okay?
Right. Okay.
And so, you know, the majority of patients never reach an out-of-pocket limit because out-of-pocket will reset every calendar year or every policy year if it's a fiscal policy. Okay? So you do need to know you're usually going to run into out-of-pocket generally if the patient has had a major surgery, you know, or if they have a lot of health issues and they see a lot of different providers, or have extensive diagnostic work done, that type of thing. That's when you're going to see a lot more on the out-of-pocket side of things. So, again, that's just something to be aware of. Okay, benefit limits. For behavioral health, there a lot of times benefit limits, like a maximum lifetime benefit for behavioral health. If you have a patient that has been seen all their life, or they've been going to counseling ever since they were very young, and they continue to go to counseling, and they have the same insurance, they may reach their benefit limits, their maximum lifetime benefit limit. But most of the time what we find is that there are annual benefit limits, like up to X number of dollars per year paid out in behavioral health claims. Pre-authorizations can be a factor in, in the what to collect from the patient and knowing what gets paid and what does not get paid. Pre-existing clauses, not so much anymore with Obamacare. Pre-existing clauses are no longer. However, there are some policies that still are allowed to have pre-existing condition. But usually when you verify benefits, they will say something like there is no pre-existing, or pre-existing does exist on this patient, and then you can find out what that pre-existing clause is. Non-covered services, certain behavioral health, maybe certain types of behavioral health services are not covered, like group counseling or family counseling. You need to know that when you're verifying benefits. So you should be verifying not only whether behavioral health is covered, but whether certain types of behavioral health services are covered. Do they cover the crisis codes? Do they cover certain diagnostic tests, and so on and so forth. HSA stands for Health Savings Account, or MSA, Medical Savings Account. They're one and the same. These are plans that are usually high deductible plans that allow the beneficiary or the patient to contribute money to a health savings account in order to build up enough funds to meet their deductible. And then that money can be used against medical expenses while they're in that deductible period. The cool thing about HSAs is that they generally can be used for medical services that are not even covered under the patient's plan. So people can use HSAs for things like glasses, dental work, for daycare. I mean, there's all kinds of things that are covered under an HSA that the patient could use that money for. So unfortunately, just because a patient has the HSA does not mean that they have funds in there to cover that deductible. So if you do verify benefits and you find out that a patient has an HSA plan, you need to verify whether there are funds available in the HSA, and you need to find out how to get those funds. Some patients are given a debit card, and you would just run their debit card. Some patients, you actually bill the carrier denies the claim, sends it on to the HSA, and then the HSA sends a payment to you. So there are different ways that HSAs are administered, and you would need to know, the ones that you would commonly come across in your area, okay? Patients, again, their summary plan of benefits, the booklet that they receive when they sign up for insurance, will outline these additional factors that could affect their out-of-pocket costs for medical services. So, with all of that said, this webinar was just to give you a really good overview of insurance in general and what you kind of have to deal with on a day-to-day basis. But I do want you to remember that insurance policies are always and always have been a contract between an insurance company and the patient, not the doctor or the healthcare provider. And a lot of times we get caught in the crossfire, so to speak, where the patients want us to go above and beyond what we really need to do to help them get paid, and they want to have as little to do with it as possible. And as a medical biller, one of the things that you need to be able to do is know who is responsible, and it will help you with your billing and collections process. I'm all for empowering patients to take control of their insurance benefits and what is being paid and what is not being paid. And I will try to work a lot when I'm in clinics. I will really work with counseling patients on how to handle their insurance, because it's as much of a kerfuffle for them as it is for us sometimes. And
Right.
They're confused, but at the same time they do have to take ownership and responsibility for the plans that they chose, whether they unknowingly chose a plan that their employer, I guarantee you, if they had an employee plan, that employee plan, the employer usually will come to you and say, all right, these are the 3 levels of plan we have. This is one, and this is one. This one has the lowest premiums, but the benefits aren't as good. Then we have ones that have higher premiums and better benefits. Which one do you want? We will contribute 50% into this plan. Well, patients a lot of times will, choose the cheapest insurance, but you get what you pay for.
Yeah.
So it's very, very important for you to empower your patients with a good knowledge of what their financial responsibility is, and not kind of stick your head in the sand about it and have your patients stick their head in the sand, because the bottom line is behavioral health services can get expensive if the insurance is not billed correctly, or if the patient lets the bill get too out of hand, and then kind of good luck getting paid at all. You know what I mean? So, okay, that concludes our presentation.